Hello class, I'm going to give you your online lecture for week 6, day 1 on the concept of stress and coping, and our exemplar is the anxiety disorders. I'm going to go over this particular PowerPoint that I just created, and there's also another one on stress and coping that assesses a person's stress level as well. Alright, let's talk about some of the material from your assigned reading. Let's look at the prevalence of anxiety disorders. They're the most common mental health disorders in the United States. It impacts about 40 million people a year in the United States. General anxiety disorders affects about 6.8 million adults, and more prevalent in women, about 2 times more likely to occur with women than men, and may develop any time in the life cycle, but you're at greatest risk for developing anxiety disorders in your adulthood. There's 2 types of anxiety disorders, OCD, which is also known as obsessive compulsive disease. That affects about 2.2 million, or about 1% of the population. And then phobias, which affects about 19 million, or 8.7% of the population in the United States. And as you can see that, these are pretty prevalent and really do cause our patients a lot of stress and can affect the quality of life. Let's look at the genetic considerations as well and the risk factors. Gender does play a significant risk factor associated with anxiety and stress-related disorders. Women are about twice as likely as men to develop an anxiety disorder, and this is because women are more sensitive to low levels of the stress hormone, gonadotropin releasing factor. But women are not more susceptible to every type of anxiety disorder. For example, OCD and social anxiety disorder are equally common in both men and women. And then both genetic factors and life experiences also contribute to anxiety disorders. Anxiety disorders tend to run in families, and the trend related partially to genetics and partially to the environment in which they're around. And up to about 50% of patients with panic disorder and 40% of individuals, and 40% of people with general anxiety disorder have close relatives with this disorder, and individuals with close relatives who have OCD are about 9 times more likely to develop OCD themselves. And many children also develop fears and anxieties that are very similar to what their parents have developed. And for some patients, exposure to trauma or a significant event may trigger an anxiety disorder in an individual who are genetically susceptible to one. And other factors may also influence the development of anxiety disorders, and that includes some personality traits that people develop. And one of those types of personality traits would be a child who's very shy. And so someone with that particular personality trait are at an increased risk. Traumatic events, including a history of maybe a spousal or childhood abuse, and also kids that are even bullied, also increase the risk of impairment. And then social factors, especially limited or absent socialization and living in a threatening environment, increase an individual's susceptibility to developing an anxiety disorder. Even hypersensitivity of the amygdala, which is that brain's fear center, is believed to be a potential factor that may increase the likelihood for development of one of these anxiety related disorders. So what we want to look at is health promotion, and obviously the focus is to decrease the exacerbation of symptoms and identifying healthy coping behaviors where the patient is excited and motivated to use. And you have to also consider that when your patients or your clients have very high anxiety, they're not going to be able to retain ways in which to cope, and they may need some various and very different interventions. Family wellness promotion is very important. It is essential to help enhance the physiological and the psychological outcomes for patients of any age, okay? And there is a link between the neglect, between the development of mental illness and child abuse, and the neglect serves to emphasize definitely this particular point. And the research also suggests that childhood abuse is associated with an increased risk for physical and psychological disorders, including depression and anxiety, and that's really something that we could obviously understand why. So let's look at some of the ways in which we can, teach our patients about promoting wellness when they're suffering from any type of stress and any type of anxiety. The first thing is obviously physical exercise. Teach the person about how exercise will benefit them, and it helps not only improve some of the physiological conditions such as cardiac and pulmonary function, but it also helps with muscle tone, joint mobility, and weight control. And exercising also helps to relieve a lot of the stress, a lot of the tension. Another thing to discuss with the patient is sleep patterns, promoting a healthy balance between sleep and rest and activity. And we've talked a lot about this in the past, about good sleep hygiene habits, and of course nutrition. Encouraging the person to eat a balanced, nutritious diet, and to teach patients that inadequate nutrition reduces that physical resistance to illness and increases susceptibility to disease and illness. And of course, time management. Teach patients how to balance fulfilling personal responsibilities, work, their families, school, and socialization. And the last one is boundary setting. And this is a quite important piece of a person's life where they have to learn how to say no if people expect more from them. The more we take on, the more stress we seem to take on as well. So that's a really important aspect of teaching people about boundary setting. Really looking at your life realistically and seeing which of those requests that you can meet in a substantial amount of time without risking your mental health and causing you to experience more stress. And with our patients, let's go back and look at that nursing transactional model. It really is part of a anxious patient's environment, and it can influence change through nonverbal, and we can influence change through nonverbal and verbal cues. And what we as nurses need to do is to inspire confidence within our patients, and some of the things that we can do is focus on the person. We should be making good eye contact and as appropriate, and having minimal amount of distractions within that interaction between you and the patient. The next one is taking a non-threatening stance, and definitely to validate your patient's feelings. It's kind of being more empathetic, where you say, I know you are very uncomfortable, we will do everything we can to make you feel better. And that should be our kind of way in which we should present the situation to the patient. And then to determine and address the client's immediate concerns, and definitely address the client by name. Try not to use such terms as honey or sweetie. It can be very demeaning to the patient. Anybody that's over 18, you should be calling them Mr. or Mrs. or Doctor or whatever. Or you might just want to ask the patient, what do you want to be called? Because you need to be respectful, and that also establishes a very good relationship between you and your patient. Now, it takes a lot of work on our part to definitely assess our patient's level of anxiety and stress. And so our first thing that we do is that physical assessment. All right? And what we're going to do is observe and test many of the body's symptoms for physical manifestations. And this could be done by the actual examination as well as a patient interview. Looking at their GI system. Are they having any signs of stress related to constipation, diarrhea? Do they have a dry mouth? Are they nauseated? The integumentary system. Are they very pale? Are they sweaty all the time? Are they diaphoretic? Neurologically, do they have insomnia where they're having problems sleeping, fatigue, headaches, and they're just very restless? Of course, looking at their cardiovascular and respiratory signs. Are they tachycardic? Or are they breathing very fast? What about their endocrine system? Do they have high blood glucose? Are they going to the bathroom a lot, urinating frequently? Some of the motor symptoms may include sluggish or stiff movements and muscle tension. And stress and anxiety may also manifest in behavioral habits as you're looking and observing your patient. Have they had problems with cutting? Are they constantly, biting at their fingernails? Or are they kind of showing sadness by crying and demonstrating a lot of gloom and doom? Remember that physical manifestations of distress may not be apparent when cognitive coping is effective, but it doesn't mean that they're not dealing with it. And then, is there a way in which we can diagnose anxiety, stress? Obviously, we can find out a lot about our patients through client interviews and through some of those subjective symptoms. And medical testing may be done to rule out any medical etiology. And what I mean by that is some of your endocrine problems really can dramatically change a person's personality. So you want to make sure that there's no serious problems such as a tumor in one of those areas where hormones are released, that this is all a psychological problem and not related to a physical one. And these diagnoses should be done by a trained mental health professional or even an advanced practice psychiatric nurse. Because you want to make sure that we're definitely defining the problem, okay? And remember, look at patients from different cultures. Even though we talked in Nursing 100 about cultural diversity, that's something that we must always think about. Are we still exhibiting good signs of cultural diversity with our patients? And so sometimes what is normal in a culture, we don't want to definitely attribute that as some abnormal response or abnormal behavior. We have to be very respectful of our patients' cultures and how they attribute or look at different life situations as well. So when we realize that our patients do have some degree of stress and anxiety, what are some of the interventions that we can definitely provide to these patients. And one thing is obviously therapeutic communication. Encourage the patient to obviously achieve optimal health, teaching them about relaxation techniques, and of course going back to validating that patient's feelings and to reinforce positive coping efforts that they are trying to utilize within their life, and just really making them aware that you are their advocate, okay? We don't want to show any type of any discrimination towards someone who may have some type of mental illness. And according to the United States Department of Housing and Urban Development, in 2013 and 2014, an estimated 20% of homeless individuals were experiencing mental illness. Even when provided with housing, these individuals were unlikely to remain off the streets unless they received access to continued health care treatment and services. And every individual and nurse who cares enough about the plight of individuals living with mental illness has the ability to impact public policy. So that's just an example of what impact we can have on those patients as well. So let's look at some of these collaborative therapies that we may implement for our patients. And one is psychotherapy. It's a preferred method of treating anxiety and some of these other psychiatric disorders. And what this involves is just basically talking with our patients by a competent and a reliable mental health professional. That could be anyone from a psychiatrist, a mental health nurse, or even an advanced practice psychiatric nurse, a psychologist, or even a social worker. Sometimes, depending on how serious the anxiety or depression or stress is in a person's life, will determine if that person does need to be admitted as a patient so that they are in a safe therapeutic social setting. All right, and also an intervention that really does help and protect the patient from the outside stressors of life can be very beneficial, because within those hospitals, many times group therapy is provided for the patient, which can really give them a lot of help and just offers that person a lot of really great support. The next one is cognitive behavioral therapy, and these are techniques and behavior modifications to just kind of help change their way of thinking about some of the detrimental beliefs and thought patterns they may have. And so the goals of cognitive behavioral therapy are to enhance problem solving and coping skills. And this is done through the care and the help by a therapist. And what they do is just try to help the person kind of self-reflect and identify what are some of those negative thought patterns that they may be having, and helps that person to kind of reconstruct their thoughts and beliefs. And through analysis and reinterpretation of the past and current experiences, then the client is able to learn and apply new skills that help promote healthy behaviors and positive interpersonal interactions. So those are some of the collaboration therapies. And then I have this other PowerPoint here about stress and coping, which is the assessment of stress in patients. Remember, homeostasis is a state of dynamic balance between, stress is that body's reaction to stimulus that demands change and does disrupt that homeostasis. And a stressor, remember, can be either physical, mental, or emotional. And there is always some type of stress response or some kind of coping ability when we face that stress, and we adapt to the situation. Not always in a positive way, but we do adapt. And, If you look back at your reading too, from Nursing 100, the types of stress: acute time limited, sequential events after initial stressor, chronic intermittent, chronic permanent, and some of the internal stresses are the physical, spiritual, cognitive, emotional, and psychological, those daily hassles. And the external ones are triggers outside the individual, environment that disrupt, that demand change. And this is what we call distress. And we all can relate to that because many of us probably right now are facing a lot of distress from what's going on around the world. And we talk about the coping process. Maslow's hierarchy of needs explains how human beings prioritize needs, what needs must be met for self-actualization, and those basic needs, those physiological needs, to those higher order needs were growth related. And remember, coping with these stresses is a process, not a trade. And we can do it by various ways: problem-focused coping, emotional-focused coping, avoidance coping, approach coping, and meaning-focused coping. And each type operates at a cognitive, behavioral, affective level. We have the stimulus-based stress models, and stress is defined as a stressor, a stimulus, or a life event, circumstances, and it will arouse a physiological, a psychological reaction, and it sure does. Think about what happens when, you're ready to take a test. You're involved in a stressful situation, so you begin feeling those physiological responses. Your heart rate starts to increase. You start to sweat. Your hands may get, really sweaty in your palms. And then, of course, some of the psychological reactions are you might, just have extreme fear. And so that's kind of how you psychologically relate to that stressful situation. We're going to look at the Holmes Raw stress test scale to numerically rate how much stress you have in your life. And there is a degree of stress with every individual. Okay. And some of the response-based stress models, Hans Selye, the chain of psychological events, that general adaptation syndrome, along with the local adaptation syndrome, and then, of course, that three-stage response, which is the alarm reaction, the resistance, and then finally the exhaustion. And these we know are some of the physiological indicators. Your pupils dilate, sweat production, heart rate, cardiac output increases, skin pallid, sodium water retention, rate depth of respirations increase, urine output, and peristalsis decreases, and mouth may be dry, muscle tension, blood sugar, alertness increase. And this is all on that page where it has the human body, and I think I brought that up in Nursing 100 on the DocuCam. So that's the physiological, and then the psychological are fear, anxiety, anger, depression, and a variety of other responses. Okay, maybe your way of coping with a test is to get very angry or maybe very depressed. And then lastly, again, very much related to what I talked about with some of the other anxiety disorders are therapeutic communication, education regarding non-pharmacological relaxation techniques, encourage a client to maintain and achieve optimal health, and assist the client in identifying strategies to help meet goals, and utilize that therapeutic communication and reinforce positive coping efforts. And I know you're also learning about some of the pharmacological ways in which medications do help some of our patients who do have some of these very, very level stress problems and disorders, and even some of people who maybe develop frequent panic attacks or have obsessive compulsive diseases or things like that. So I just wanted to go over this again with you to see, first of all, we have to make that assessment about stress and anxiety with our patients, and these are ways in which we can definitely look at those physiological responses that we see with our patients to determine. We know when our patients are facing stress. We know when our friends are facing stress. And that's how we kind of gather and accumulate that information or retrieve that information from our patients to determine, at what, how much interventions or how much we have to provide these patients to help them get better. But we have the tools to do that. So what I'd like you to do now is look at Appendix 38, and I'll go back to that after you look at this Holmes Rahe Life Stress Inventory, where you look at all the life events that could possibly occur within your life. And this is all that's maybe occurred in the previous year. And you can see how many points you would get for that, and then add up those points, and then you can find out what that point value means as to how much stress do you have in your life right now. And you can see that a lot of things that we do really have a high point value. Okay, obviously any type of relationship problems where someone dies, your spouse dies, or you get a divorce, or even just marital separation, being in jail, from all the way down to even you might think a vacation would be to try to get you away from stress, and many times it does, but you still get points for that because you get 13 points because going away is stressful. And then of course any type of major holidays is stressful, and even any minor violations of the law. Say for instance you get a traffic ticket because you were speeding, you still get points for that. But you can see maybe things that relate to you. So what I want you to do is go through these. There's 43 of them, all right? See if any of these pertain to you. Give yourself those points, and then add up your points. You can see anybody that gets 300 or more points raises the odds to about 80% according to the Holmes Rahe statistical prediction model of definitely having a lot of stress in your life. And I'll bring that down to show you that. That's down here on the bottom of that page. Let's see, I think there's one in here. Going to school, if I'm not mistaken. Major change in responsibilities at work. Some people are unfortunately right now losing their job. Yes, beginning or ceasing formal schooling, you do get 26 points for that. Even an outstanding personal achievement causes stress, so you get 28 points for that. If you've moved recently, major change in a living condition, you get points for that. Changing to a new school, all those kinds of things. So what I want you to do is definitely take this stress inventory test to see where you're at. And then I want you to go back to Appendix 38, okay? And it really is a good thing for you to kind of self-reflect and kind of admit to yourself that, wow, I've got a lot on my plate, you know. This may help you realize maybe why you're not doing as well in school as you should be, because you're really dealing with a lot of stress in your life. So think about these questions too. Now think of a patient you've cared for recently. Complete the inventory again for them to the best of your ability and compile their score. How likely are they to experience a stress-induced health problem? And what type of problem do you expect to emerge? And how can you, in your role as a nurse, assist them? And I'm sure there are a few patients out there that you could think about, wow, they probably have a lot of stress in their life and their scores were probably very high. And we know the physiological effect over time when stress is consistent, heart rates are always up, it's going to affect your immune system. And this is why, especially I see nursing students tend to get ill while they're in nursing school. So definitely review that particular appendix. All right, let's take a look at Appendix 39. Assessment of stress in patients is our exemplar. All right, question 1. Describe the application of therapeutic communication in the nursing care of clients with disorders related to stress and coping. I want you to think about that. We have talked about therapeutic communication in the past. How does that benefit a patient? Remember, anytime a person is stressed, they're in a state of crisis. And so an individual under stress will have impaired concentration and memory, so the nurse must continually reassess the individual's interpretation of the events. Continual observation of both verbal and nonverbal communication is essential, and the nurse must be cognizant of tone, inflection, and their mannerisms while they're communicating with you. So this is extremely important. We learn so much about our patients through therapeutic communication. Question 2. Particularly during the care of patients with disorders related to stress and coping, why is giving advice contraindicated? What specific communication strategies are recommended for these patients? Well, the reason we contraindicate giving advice to our patient is because individuals in crisis are often unable to remember and retain information. The nurse cannot always know the full range of stressors that affect that patient, so advice might be rejected for being incomplete or unhelpful. And nurses caring for patients in crisis should use the principles of therapeutic communication, and that includes simple verbal communication and careful nonverbal communication in order to communicate successfully with the patients. And question 3. What is client confidentiality, and how does this principle pertain to clients who seek treatment for alterations related to stress and coping? Under what circumstances is the requirement to maintain client confidentiality not applicable? And that's a really good question, because there could be times when the patient really tells you some very personal information, and maybe really goes into their very deepest, darkest thoughts and conveys that to you. And so client confidentiality refers to the principle that all client information should be protected from outside parties. For clients seeking treatment for stress and coping, no aspect of diagnosis information should be shared without the client's permission. And confidentiality may be breached when the healthcare provider fears for the safety of an individual or for the public safety. If they're angry, and this is how they're dealing with their stress, and they're going to go out and hurt somebody, then you need to speak up, because ethically you have responsibility to be sure that that person is going to be protected who they might harm, or if they're going to harm themselves as well. Maybe they're thinking about suicide, and you've got to step in and be sure that they're not going to hurt themselves. This is the only time you can breach that confidentiality. And number 4, while in the hospital cafeteria, a nurse overhears a nursing colleague discussing a client's recent hospital admission for treatment related to an unusual phobia. Although the nursing colleague does not specify the client's name, she includes a detailed discussion of the client's complaints. How should this situation be addressed? Well, the nurse caught sharing confidential information should be reported to the hospital administration so that appropriate disciplinary and educational measures can be taken. This is absolutely wrong, and it violates HIPAA, and it needs to be reported immediately. So, and it's our responsibility, even as students, if you should hear this kind of conversation about any patient, you need to report it. It's your ethical responsibility to do so. And we've had, unfortunately, students that have talked about patients. It's not an intentional breach, but it does happen on occasion because they're very excited. They maybe had this incredible experience with a patient, and they go down to lunch, and they're, with their fellow student nursing colleagues, and they want to share their experience. You can't do that. You've got to be careful who you're talking about outside the hospital, and you definitely violate that confidentiality of that patient, and there's always that chance that somebody can overhear that information. Okay. All right. So what we're going to do now is look at exemplar 40. All right. I'm going to move this over here, and so let's look at this particular case study. All right. All right, so what we have here is Kevin DiLarno. He's a 23-year-old student who is completing his second year of graduate school in the study of anatomy and physiology. He presents to the University Student Health Service Center with complaints of frequent headaches, including a current headache, which he describes as a throbbing in the front of my head. He rates his pain as 7 on a scale of 0 to 10, with 10 being the worst imaginable pain. During his client interview, he denies any past medical history or any additional complaints, including trauma, visual disturbances, dizziness, weakness, or neurologic changes. According to Mr. DiLarno, his headaches are interfering with my study schedule. I have exams every week, and I can't concentrate on studying. If I don't get these headaches under control, I'm going to end up failing at least one class this semester. He reports that he drinks about a pot of coffee a day and occasionally smokes a cigar when he is socializing with his friends. Upon arrival, Mr. DiLarno's vital signs include a temperature of 97.9 Fahrenheit orally, pulse is 92, respirations 18, and his blood pressure is 153/82. Auscultation of heart and lung reveals no abnormal findings, and he insists he is fine except for these stupid headaches. I am sure it's just stress. I need something to help me get them under control so I can get my work done. And during his assessment interview, the nurse asked if Mr. DiLarno has made any recent changes to his daily routine or health habits. He replies, "There aren't any recent changes, but soon there will be. I'm getting married in 3 months, and my fiancé and I will be moving off campus. We're in the process of buying a house." Mr. DiLarno further states that he is excited about getting married, but feels the wedding planning has gotten out of hand, as he and his fiancé have already exceeded their wedding budget. When asked what activities he engages in for enjoyment and recreation, he replies, "I don't have time for anything except classes and studying. I used to work out and play racquetball 3 times a week, but I don't have the time for that right now." So we've got a very typical situation where we see a young 23-year-old graduate student who's really in life overload. So let's look at some of these questions, okay? Okay, our first question is, based on Mr. DiLarno's statements, what are his current potential sources of stress? And it's a lot. Just going to school is stressful. Well, first of all, he has psychosocial stressors. In this case, include the pressures of school, anxiety about marriage, and wedding expenses, and the financial burden of buying a house. His biogenic stressors include a lack of exercise and nicotine and caffeine consumption. So question 2, in addition to his complaints of recurrent headaches, which assessment data might reflect manifestations of the stress response? And his body temperature, his heart rate, and his breathing are all within normal ranges, but you can see that his blood pressure is quite high, and that indicates that he does suffer from hypertension. So question 3. Describe the effects of coffee and nicotine intake, including how these effects are similar to those invoked by the stress response. Think about what that is. Remember, heart rate goes up, blood pressure goes up, respirations go up. Very similar to what caffeine does. Caffeine raises heart rate, increases anxiety and restlessness. And nicotine decreases appetite, increases heart rate, and stimulates alertness. These qualities are remarkably similar to the stress triggered the fight or flight response, which increases heart rate and blood pressure while suppressing digestion. All right, so let's look at question 4. All right, let's move this over. Okay, number 4. Do positive stressors and negative stressors differ in terms of physiologic effects? Explain your answer. Well, basically they're very similar. However, positive stressors are generally associated with eustress, which typically results in achievement and the cessation of stress, where negative stressors are associated with distress, which is associated with inadequacy and may become a chronic condition. So question 5, presuming Mr. DeLarno's headaches are stress-related, what nursing diagnoses would be appropriate for inclusion in his nursing plan of care? Well, we could think of a few. All right, one of them would be a sedentary lifestyle, which would be ineffective health maintenance, ineffective self-health management, readiness for enhanced self-health management, stress overload, and anxiety. And I'm sure you guys can come up with some other ones as well. Question 6. What nursing interventions could be implemented to promote stress reduction for Mr. DeLarno? First, we could look at some problem-focused coping interventions. That would be to reduce his caffeine and his nicotine intake. He could get back into exercise and improve his study skills. And part of his emotion-focused coping interventions would be regulating his emotional response to school anxiety, his financial struggles, and the transition into marriage. Maybe it might be a good time for him to postpone the marriage until maybe he's done with school. So those are things that we could possibly encourage him to do. So let's read the rest of this evolving case study. All right, let's go on. Just let me bring it up a little bit so it's in a better eye view. All right. Mr. DeLarno is awaiting evaluation by the University Healthcare Clinic's nurse practitioner. He agrees to allow his nurse to dim his room lights while he waits. After resting quietly for 10 minutes, he falls asleep. When the nurse awakens Mr. DeLarno to reassess him, he states, "I'm surprised I fell asleep. Usually I can't fall asleep no matter how hard I try to relax. I'm only sleeping a few hours each night." He reports his headache, feels quite a bit better, but I know it's going to come back with a vengeance as soon as I start studying again. He rates his pain as 3 on a scale of 0 to 10, with 10 being the worst imaginable pain. His blood pressure has decreased to 128/72, and his pulse is now down to 78. Upon arriving to assess Mr. DeLarno, the nurse practitioner introduces herself and asks the client to describe his current complaints, as well as any similar problems he has experienced in the past. Mr. DeLarno states, "My headache is better, but I need something to help me control it while I'm studying. I think alprazolam would help. I have a friend who takes that when he gets stressed." The nurse practitioner responds by noting that she would like to further assess Mr. DeLarno, as well as ask him a few questions before making any treatment recommendations. Mr. DeLarno replies, "The nurse I saw earlier already listened to my heart and lungs, and she already asked me a bunch of questions. Headaches are my only problem. I don't need any additional workup. I can't stay here all day. Are you able to help me out or not?" Ooh, so he's getting a little testy now because he wants what he wants. And he feels that the cure for all is to put him on some kind of relaxation medication called alprazolam. So let's look at the questions concerning this part of the case study. So, question number 1. Explain the most likely reason for Mr. DeLarno's decreased headache and decrease in his blood pressure and heart rate. And I think you all know what that is. He finally quieted down. He finally had a relaxation of the sympathetic and neuroendocrine system due to dimming the lights and falling asleep, which is exactly what he needed. So what is the significance of Mr. DeLarno's reported sleep habits? Individuals who experience impairment of their functioning related to stress may develop disorders related to sleep. Lack of sleep also compounds the physiological factors related to stress. And I talked about that earlier, how we teach and promote wellness by teaching people about good sleep hygiene. So, question 3. In the event that Mr. DeLarno's complaints are related to anxiety, is a prescription for alprazolam or Xanax a preferable first approach to treatment? Why or why not? And that is a great question. So let me answer that for you. And I'm sure many of you were thinking the same thing. Xanax or alprazolam is an appropriate treatment for anxiety disorders. However, the drug is not a preferable first approach to treatment because the client must be diagnosed with anxiety before the drug is administered. The client's complaint should be treated with non-pharmacologic interventions first, and then we'll see how he responds to that or how she responds to that, and then go from there. All right, question 4. How should the nurse practitioner respond to Mr. DeLarno's seeming frustration with the need for additional assessment? Well, I think she needs to calmly express empathy and understanding of why he would feel that way, and that and we can't possibly treat him if we don't possibly further assess him. And just to let him know how long this is only going to take, it's just going to take a few minutes, but we want to rule out that there's no pathology going on with, what his symptoms are definitely exhibiting. All right, let's finish up this case study. Following Mr. DeLarno's assertion that he cannot stay here all day, let me bring that into view again, and his prompting for rapid treatment, the nurse practitioner replies, I can imagine that your headaches are interfering with every aspect of your life, Mr. DeLarno. In particular, it must be miserable to try and study while you have a pounding headache, much less to take an exam. I want to help you find the best solution, which means I'll need some more information from you. She further explains to Mr. DeLarno that additional assessment is needed to accurately identify the cause of his headaches, as well as to choose the appropriate treatment approach. Initially, Mr. DeLarno is disappointed by not receiving a prescription for alprazolam, which he again suggests will fully resolve his headaches. However, after talking with the nurse practitioner, he agrees with the plan for further assessment. The nurse practitioner performs a focused neurologic assessment, including assessing Mr. DeLarno's pupillary response to light and his extremity strength. She also interviews him as to the presence of any alteration in sensory perception, including numbness, tingling, or other unusual sensations. With the exception of his headache and sleep disturbances, which Mr. DeLarno reports began about 8 months earlier, his assessment findings reveal no abnormalities. Based on assessment findings, the nurse practitioner suspects Mr. DeLarno may have developed generalized anxiety disorder, and for further evaluation and treatment, she refers him to the Student Wellness Center, the staff of which include a psychiatrist and other mental health specialists. She further instructs Mr. DeLarno to avoid caffeine and nicotine and to contact the clinic if his headaches worsen or if he experiences any alteration in sensory perception. Additionally, she offers to refer Mr. DeLarno to a local massage therapist who offers one free massage to students referred by the University Student Health Services Center. The client agrees to follow up with the Student Wellness Center and pleasantly accepts the referrals for massage, stating, "I'm calling the massage therapist as soon as I walk out of here." All right, so we're seeing some positive things begin to happen. All right, so let's look at question 1. Which of the nurse practitioner statement represents validation of the client's complaints? Explain how validation can serve to diffuse a tense verbal interaction with a client. The nurse practitioner's expression of understanding that the client's headaches are interfering with his whole life is a validation of the patient's complaints. Validation will show the client that the healthcare system is on his side and that his frustrations are being taken into account on his path to diagnose and to treat him. How could the staff nurse support and facilitate the interventions prescribed by the nurse practitioner? They can support and facilitate the nurse practitioner's interventions by providing the client with resources about GAD, making sure he has the contact information for the health clinic and massage therapist, and encouraging him to follow up with any questions or concerns. All right, let's see. We got a couple more questions here. All right, question 3, again, identifying nursing diagnoses that are appropriate for inclusion in Mr. DeLarno's nursing plan of care. And again, some of the same ones: sedentary lifestyle, ineffective health maintenance, ineffective self-help management, readiness for enhanced self-health management, and stress overload. And question 4, what additional recommendations could be offered by the staff nurse to promote healthy sleep rest patterns for the patient? Obviously, get him back into exercise, cognitive behavior therapy, sleep medication, meditation, and relaxation techniques. And again, some of those other things we said. Time management is huge. And, boundary setting, only doing as much as you can handle without putting more stress on you. And looking at your life, your personal life. Is there things that he can change to alleviate some of the stress in his life that he feels so overwhelmed? So I think that kind of helped. It kind of brought together what some of the things that were in the PowerPoints and in your reading, that this is real for all of us, stress and coping, all right? And obviously some of us have more stress than others, but it's how we cope and how we deal with it, because it's always going to be there. But it's to what degree and how well am I able to cope that it starts to affect me physiological as well. And that's what we see happen, unfortunately. Class, we're going to kind of shift gears now and look at cognition, because our behavior and our thought process is a way in which we can help deal with our stress and anxiety. Cognition is basically a complex set of mental activities. It's mental action or a process of acquiring knowledge and understanding through thoughts, expression, and through our senses. We acquire it, we process it, we store it, we retrieve it, and we use that information. And it involves different processes of awareness, remembering, reasoning, decision-making, understanding, and using language. So this is some of the physiology review, where cognition primarily is the brain's responsibility in the cerebrum and in the limbic system. Within the cerebrum, we have the anterior portion with two hemispheres, where you have complex sensory and neural coordination of our voluntary activity. And then within the limbic system is our thalamus, our hypothalamus, and our basal ganglia. And the hippocampus is where we form new memories, and of course neurons and neurotransmitters. And those are important to understand because, when we give medications, those particular ways in which messages are sent are definitely affected by some of the medications that patients take. And then we look at theories of cognitive development. Piaget's theory in children, where it involves sensory motor, pre-operational, concrete operational, formal operational. It's a complex theory about the nature and development of human intelligence with 4 distinct stages of birth to 2 to 7 years of age, 7 to 11, and then adolescence to adulthood. And then Vygotsky's theory, children learn through their culture and through social interactions with other people, and that's when we see kids develop and engage in social activities as well. And then, of course, information processing theory, where the mind is continuously evolving computational system that takes in information, operates on it, and converts it into answers. And of course, genetic considerations and non-modifiable risk factors. Cognitive skills become increasingly complex, advancing from childhood to adulthood, and that makes absolute sense. And changes in cognition are experienced by older adults, again, as we age. It's part of the normal process. Alterations sometimes do unfortunately develop in the process of aging. Perception, the ability to interpret the environment, can be affected by impaired senses, and we talked a lot about that with sensory perception. Cognitive ability, often information processing speed, decreases with aging. Impairment that interferes with normal life is not a part of the normal aging, where dementia or things like that is not normal aging processes. And then memory, short-term memory changes very little. Long-term memory, you can see a more noticeable decline. When older adults are trying to learn, they need additional time, but they also need the motivation behind it to want to learn, okay, to make their life have more quality and be more productive as well. And normal healthy aging is not characterized by cognitive or mental disorders. There should be no significant memory impairment. Mental health, cognition should be stable with normal age-related changes. And those people should also be able to develop methods for coping with those age-related changes as well. And I'm sure you could relate to some of the patients that you cared for in the long-term facilities where we could actually do this mini mental state exam, and I think I did bring this to your attention in Nursing 100. And this is something we can do to definitely assess, is there any alterations in their cognitive thinking? And I'm not going to go over these individually, but I want you to look over these because some of these can be somewhat difficult, so it really does give you a good indication if the patients are having, memory problems, dementia, or whatever the case may be. So please be sure that you go over these and look at all the different activities that we require in the mini mental state exam. And again, there is a possible maximum score of 30 points. And this can be quite challenging for some of our patients as well. So again, the mini mental state exam, where it talks about orientation, registration, attention and calculation, recall, and language. Okay, those are the categories. And we jot down here on this far left-hand column as to what the residence score is. So make sure you review that. And just to remind you that with that mini mental state exam, a score of 23 or lower indicates that there is some kind of cognitive impairment. And remind your patients that it can only take about 5 to 10 minutes to administer it. and therefore we can use it quite often and even repeat it with some of our patients, okay? But remember, as I said before, the tool is not able to diagnose the case for changes in cognitive function and should not replace a complete clinical assessment of mental status. In addition, the instrument relies heavily on verbal response and reading and writing. So if your patients can't hear or can't see well, or if they're intubated or have a low English literacy, say for instance English is their second language, or anybody that has some kind of communication disorders, may perform poorly even when their cognition is intact. So just remember that. I just wanted to remind you about that. All right, we're going to kind of shift gears now. We want to talk a little bit about some of the eye disorders. And the three eye disorders that I want to talk about are cataracts, glaucoma, and macular degeneration. All right. And cataracts are part of an aging process, and you want to think about what structures each of these diseases of the eyes do affect. And remember, as we begin to age, the lens ages, and its fibers and proteins change and degenerate. And so what happens is those proteins begin to clump, and you have clouding of the lens and reduces the light to the retina. And we'll talk about the 4 different types, all right? So pathophysiology and etiology, there is opacification of the lens of the eyes. The process begins at periphery of lens, gradually spreads to center, and it interferes with light transmission to the retina, ability to perceive images. It does result as one begins to age. And 50% of individuals between the ages of 65 and 74 will develop cataracts, and 70% of those older than age 75 will get cataracts. There are 4 types that occur independent of the aging process. The first one is secondary. Forms after surgery to treat another eye disorder or effects of medication or another primary disorder. Traumatic is a result from injury to the eye. Radiation, where there's long exposure to radiation. And congenital is in which a child at birth or in their childhood develops cataracts. All right. So what are the risk factors? What increases the chance or the risk of developing them is definitely age and your genetics, depending on, your parents. And of course, environmental and lifestyle factors, long-term sun exposure, cigarette smoking, heavy alcohol consumption, eye trauma, diabetes, and of course, medications. And so prevention, really no known methods, and risk reduction. Don't smoke, don't drink a lot, and protect your eyes from the UVB rays, and diets that have sufficient amounts of vitamin C and E, lutein, and zeaxanthin. Okay, will also help reduce the chances of getting cataracts. Okay, the second eye disorder that we're going to talk about is glaucoma. And we kind of refer this problem with the eyes as the silent thief of vision. All right, and we'll look at the different types of glaucoma. The first one is primary glaucoma, where there's no identifiable cause. Usually open angle glaucoma is more common, and it's a gradual or a chronic progressive loss of vision, most common form in adults. And what happens is there's a flow of aqueous neuronal ischemia and optic humor, where there's nerve degeneration, which will affect both eyes. The second type is angle closure glaucoma, and that's a rapid permanent vision loss if not treated. It may have intermittent episodes associated with factors that cause the pupils to dilate. And what happens is there's a corneal flattening or bulging of the iris into anterior chambers. Intraocular pressure rises abruptly, and it damages the neurons of the retina and the optic nerve, and you have a rapid or a permanent loss of vision. So those are the two types, primary and angle closure glaucoma. And with glaucoma, it's the leading cause of blindness worldwide. Obviously, age and race are contributing factors of why you would end up with glaucoma. Family history, long-term steroid use, and eye trauma, where you have secondary glaucoma years later. And exercise will decrease intraocular pressure. Again, diets that are high in vitamins, carotenoids, and omega-3 fatty acids are good to intake of. Prevention is prescription eye drops for individuals at high risk. Obviously, going to your eye doctor as you begin to age to identify the problem early. Exercise lowers intraocular pressure, as I said before, and prevent overexposure to sunlight, and definitely do not smoke cigarettes. So these are the prevention, okay? Okay, and the last eye disorder I want to talk about is macular degeneration. And it is legal blindness of people over 60 years of age. And it is degeneration of the macular area of the retina. And there's two types, non-exudative or dry age-related macular degeneration, where you have gradual accumulation of deposits. Pigment epithelium detaches in small areas, becomes atrophic. Vision loss typically not significant, and it progresses very slowly. Risk that the disorder will progress to exudative stage. Exudatives. All right. And with exudative or wet macular degeneration, you have vascular endothelial growth factor, causes the growth of abnormal blood vessels and potential spaces between the choroid and the retina. And so new vessels prone to leak, elevate retina from choroid, distort vision, bleeding can occur, and that's when you have acute vision loss, always preceded by dry macular degeneration. This is one of the top causes of severe vision loss, legal blindness in Americans. And what happens is with this type of a wet macular degeneration, these vessels are just not consistent with good integrity, and when they bleed out, they tend to leave a lot of scar tissue behind, and this is what causes the vision loss, okay? Again, risk factors, aging, more for women than men, smoking and alcohol. It's about 15 million people that end up with this type of eye disorder, okay? Let's look at some of the manifestations. Usually with exudate macular degeneration, you have glare, color discrimination between blue and purple, and pupil may appear cloudy, gray, or white, and the person will definitely have photophobia. And again, with cataracts, clinical manifestations, visual acuity decreases affecting close or distant vision. And again, with cataracts, you can have glare, affects ability to adjust between light and dark environments, and tends to occur bilaterally unless related to eye trauma. One cataract generally matures more rapidly than the other. And with glaucoma, open angle, often no symptoms. Blank spots start to appear in visual fields. And then angle closure can cause intermittent pain or photophobia. And then acute angle closure, severe eye, face pain, malaise, nausea, or vomiting, or an abrupt decrease in visual acuity. And these are the people that we collaborate with who really do have expertise with eye disorders. The ophthalmologist, your occupational therapist, orientation and mobility specialist, low vision therapist, social worker, or a vision rehabilitation program. All right, we look at some of the diagnostic studies, especially with cataracts, history, Snelling and Rosenbaum charts, and we can also have the ophthalmologist do a dilated eye exam as well. When we look at glaucoma, which has to do with pressure, one of the tests that we might see done is the tonometry, and that indirectly measures intraocular pressure. You can either have a contact or a non-contact tonometry may be used. We really recommend this test for anyone over age 60. A single elevated pressure reading does not warrant a diagnosis of glaucoma because sometimes we see about 50% of patients with glaucoma will not have high intraocular pressure on exam. So if you do that single testing, it may miss that actual diagnosis. The next one is a fundoscopy, and that's an actual visual inspection of the optic fundus using an ophthalmoscope, also called ophthalmoscopy. And it identifies pallor and an increase in the size and depth of the optic cup on the optic disc. And then the next one is a gonioscopy, which uses a gonioscope to measure the depth of the anterior chamber, and this test differentiates open angle from angle closure glaucoma. So this gives you a little bit more detail. And then visual field testing identifies the degree of central vision field narrowing and peripheral vision loss. Because somebody that has glaucoma may have 20/20 central vision even when there is severe peripheral vision loss. Okay, so that's with cataracts and glaucoma. And then with AMD is diagnosed through vision and retinal examinations. And the Amsler grid was developed as a diagnostic tool for AMD, and patients with wet AMD will report the same symptoms as those with dry AMD, with the addition of visual distortions. And usually with AMD we do pupil dilation. All right. And it's important to explain a lot of these procedures to the patient, and especially if you've never had it done, it's important that the physician or the doctor doing it will explain what's going to happen with pupillary dilatation exams. How it's going to be done, what to expect, and that this dilatation of that eye is just temporarily. And then they also can do fluorescein angiography on the patient, and these are when they actually take pictures as the dye passes through the blood vessels of the retina, allowing detection of those leaks, of those like bad blood vessels that are leaking out that blood and that drainage. And then optic coherence tomography is relatively new. It is a non-invasive and involves taking cross-sectional images of the retina to measure its thickness, and areas with thinning are noted in patients with advanced AMD. So new things, and really this is quite interesting for me because learning about these as I begin to age really puts me more in an awareness of how these eye problems can start to develop. And we're not going to go into any of the pharmacological therapies. You'll get those in your pharm class. So with cataracts, what is the surgical treatments? Well, surgical removal is the only treatment for cataracts indicated when the vision and activities of daily living are affected. Typically, that's done as an outpatient using local anesthesia. Most common is the extracapsular extraction. And what they actually do is the anterior capsule, the nucleus, and the cortex of the lens are all removed, leaving the posterior capsule intact, and it's one of the most common surgeries. And so what they do is the surgeon will make a small incision at the edge of the cornea and extract the lens intact or via emulsification and aspiration. And after removal of the lens, the eye can no longer focus light on the retina and the vision is seriously affected. And so what they'll do is they'll put in a plastic or acrylic or a silicone intraocular lens that is implanted at the time of the surgery that rapidly restores binocular vision and depth perception. So that's that. Typically, one eye is done on one eye at a time, and 10 to 50% of patients may develop opacification 3 to 5 years after surgery, vision restored by another procedure. And then let's look at the surgical interventions for glaucoma. Will improve the drainage of the aqueous humor, and the first one is a laser trabeculoplasty, and what this is in which the doctor will use an argon laser, and it creates multiple burns spaced evenly around the trabecular meshwork, and they begin to heal, and then there's tension on the resulting scars that stretches and opens the meshwork. And this is a non-invasive technique, requires no incision, and can be performed as an outpatient procedure, making it the treatment of choice. In a trabeculoectomy, this is a permanent fistula is created to drain that aqueous humor from the anterior chamber of the eye into the space under the conjunctiva, where it can be absorbed into the systemic circulation. This particular procedure is performed under general anesthesia, and it does require hospitalization. If these procedures are not effective, they can do argon laser or cyclocryotherapy. And what they'll do is those essentially destroy portions of the ciliary body. And this reduces the production of actually the aqueous humor. And another surgical procedure involves inserting a glaucoma drainage device that regulates the outflow of the aqueous humor. And if the patient has acute angle closure glaucoma, That may be treated surgically with a gonioplasty, or also known as iridoplasty, a laser iridotomy, or peripheral iridectomy. And so those are things that can be done. And with wet age-related macular degeneration, that's usually treated with laser surgery or photodynamic therapy. They don't actually cure the disease, but they may slow the rate of vision loss. And in laser surgery, fragile blood vessels are destroyed, preventing them from bleeding out. And in the photodynamic therapy, they use a drug that tends to adhere to the surface of the new blood vessels. And it's injected systemically, and then shining a light into the affected eye activates the drug and destroys the new blood vessels. And this risks include damage to surrounding healthy tissues, some vision loss, and continued growth of new vessels. And with cataracts, really there's no medication available. Usually they don't do the surgery unless it does interfere with daily living, and the person learns to manage living with early cataracts. They might use such devices as a magnifying glass, a stronger prescription lenses, brighter light, and anti-glare glasses. With glaucoma, relaxation, regular physical exercise lowers that intraocular pressure. Angle closure glaucoma is not responsive to exercise. And with age-related macular degeneration, can be slowed in early to intermittent stages of dry AMD, high doses of antioxidants, especially zinc, and again using some of those other assistive devices, magnifiers, large printed books, high-intensity lighting, computer tablets, e-readers, and audiobooks and podcasts. And this is just the lifespan consideration. With infants and children, obviously with cataracts, that would be referred to as congenital cataracts. Causes may be from maternal infection during gestation, galactosemia or other metabolic disorders, genetic mutations, trauma, and very few related to rubella, often asymptomatic. With congenital cataracts with children and infants, signs of possible cataracts where you might see a lack of reaction to bright light, failure to notice toys or faces, unexpected environmental delays. Testing is pretty much what we do with the adults, and surgery of vision as impairment is significant, and even intraocular lenses may be implanted. With pediatric glaucoma, 10% is diagnosed at birth. 80% diagnosed by age 1 is infantile glaucoma, and diagnosed after age 3 is called juvenile glaucoma. Secondary congenital glaucoma cases are these different syndromes. With pediatric glaucoma, it's difficult to diagnose. They may have photophobia, epiphora, ophthalmos, blepharospasm. Treatment is, again, that trabeculectomy or goniometry. Also eye drops, oral medication. 80 to 90% promptly diagnosed, treated, have normal, near normal vision throughout their life. Juvenile macular degeneration, different pathology from age-related macular degeneration. These are the different types. Stargardt disease, most common type. Best disease, juvenile retinocytosis. Central vision loss, one eye may be more affected, no treatable or preventable ways to avoid this. right, looking at pregnant women, glaucoma, relatively rare in women of childbearing age. Many medications for glaucoma have potential adverse effects on the fetus. Argon laser trabeculoplasty is relatively safe, only short-term benefits, adequate until woman has delivered baby. Remember, as the person begins to age, older adults, especially if they have to put in eye drops, if they have hand tremors, make it very difficult to apply eye drops. Cognitive decline may cause forgetting to take medications. And as always, providing a safe environment and alert for potential eye diseases in all patients. And again, as we make that assessment with our patients, observation and patient interview, observe any general difficulties with vision, assess effects of vision changes in their lifestyle activities, and kind of look at their lifestyle habits. Do they smoke? Are they diabetic? What kind of medications are they on? Assess their family history, signs and symptoms of new rapid onset of age-related macular degeneration. Going for physical exams, testing general distant and near vision, testing peripheral fields, testing on Amsler grid, and examinations for specific disorders depending on patient signs and symptoms. And these are all the types of nursing diagnoses that may be included on a care plan with some of these patients. I'll let you read that. And of course, a lot of this is related to hoping, and the goal for that patient is to remain free from injury, being able to articulate and understand the reasons for and risk involved, express feelings related to diagnosis and reduce vision, and make it more patient-centered care where they are participating in their own self-care and to be able to follow self-care instructions. A lot of feedback, a lot of demonstrations so that they're able to put in their eye drops correctly and do some of the things that are needed. And preventing injury, is there any way we can make sure that that has all been implemented in the patient's home? Provide instructions related to vision loss, changes in depth perception, and being careful that we're not changing the dynamics of the room around. So we're keeping the furniture and all the other needed appliances in the respective place so the patient's aware of that. And then promote wellness and teach principles of self-care, of course. And then, of course, to facilitate orientation and environmental modifications, orientation to the individual speaking and the environment, reduce anxiety. At each interaction, address patient by name, identify self, orient the patient to time, place, person, and situation, and state the purpose of the visit. All right, let's get out Appendix 42 and look at our concept of sensory perception. Exemplar is cataracts, okay? So we have Mary Martin. She's a 75-year-old widow with osteoporosis. She has an appointment with her ophthalmologist this week. The ophthalmologist notes that Mary's cataracts continue to worsen and recommends that she consider surgery. Mary does not admit the fact that she is afraid to have surgery on her eyes, and she tells the doctor that she might have the surgery at some point, but that she is too busy to do it right now. The physician gives Mary a new prescription for her eyeglasses, knowing that this will help her vision at least for a little while, and Mary is told to increase the amount of light and to use reading glasses or a magnifying glass for reading. So what nursing diagnosis would be appropriate for this patient? So I want you to think about that. And she's lacking the compliance to have the surgery because they are really beginning to progress. And we could also say that it may affect in the future her safety, so altered safety that's is exhibited by her impaired vision. Question 2. How will the nurse address the client's concern regarding surgery? I think we have to continue to explain the procedure and that her vision could continue to get worse, which may interfere with all the normal things that she does in her daily life. And so, and we also worry about, unfortunately, her safety. If she still continues to take care of her house and she still continues to cook, if those cataracts get worse, this may definitely prevent her from doing some of the things that she enjoys doing. So it's something for her to think about. And I think you need to tell her exactly what is involved with the treatment or the surgery for the cataracts. You know, maybe she's just very fearful. Maybe she knows someone who had a bad experience when they had their cataracts removed. So we have to kind of put those perceptions in check to make sure that she knows exactly what's going to happen. And maybe she's worried about the recovery time as well. So what factors may impact Mary's home care? Anything that has to do with stairs, rugs, lighting, just living alone and she doesn't have anybody to depend on to help her with things. Her mobility may be somewhat affected because of the osteoporosis, and she's definitely at risk for falls and fractures if her eyesight begins to deteriorate. And we don't really know about her other medical problems. We don't know how her hearing is as well. So this could be a big problem, okay? So that's Appendix 42 on cataracts. So let's look at 43. So the nurse is caring for a client undergoing surgery for cataracts. This client is 78 years old and lives alone on a 3rd floor walk-up with no elevator. Oh boy. That might be hard for a lot of people, not just someone who's 78. So again, we're looking at safety. What safety issues will the nurse address when teaching this client? Use side rails when walking up the stairs. Make sure her shoes are not slippery on the bottom. Make sure she's got good lighting so she can see the stairs. Make sure she takes it slow. So she's aware of any obstruction in the stairwell that she could trip over or fall, so that she looks at each step to make sure there isn't an item on that step that could cause her to fall or trip or sprain her ankle or fall down the stairs. Because this could be very serious. She's going up 3 flights of steps and she's 78 years old. So I'm not sure this is a great place for her to live. So what issues place this patient at risk for injury? Of course, it's her age. She's 78. And she's also, we don't know her other comorbidities. But, you know, as we age, she probably has mobility issues, a little bit of arthritis. We don't know how her coordination is. So, and maybe she has to use a cane or something. We don't know about her cardiac and respiratory status. Maybe she's got lung issues and this is really hard for her to walk up the stairs, or maybe she uses oxygen all the time. So these are all things that we need to consider. Okay, and then question 3, how might the development of cataracts interfere with the older adult's ability to meet developmental milestones? Obviously, her sight and mobility may be definitely compromised with her cataracts. And then question 4, prior to cataract repair, What interventions might be the nurse initiate to help the older adult meet his or her developmental needs, making sure that she understands medications, review drugs with the patient, no alcohol, or if she does drink, have it limited, wear sunglasses out in the environment, and maybe the need for supplemental vitamins to prevent reoccurrence of cataracts or other eye disorders. All right, let's look at Appendix 44 on glaucoma. Jane Baker is a 75-year-old female who is recently widowed. She and her husband were married 40 years when he died from cancer. She has limited income because her husband's pension terminated when he died. She receives $652 a month in Social Security benefits. Mrs. Baker does not see particularly well. She has an excellent health. The only health-related problem is she's aware of our osteoporosis and glaucoma, for which she sees an ophthalmologist on a regular basis. The only prescription drugs and over-the-counter supplements she uses are Fosamax calcium and latanoprost ophthalmic solution, which is also known as Zalatan eye drops, to manage her glaucoma. Her dose is 1 drop in each eye once a day. Her only complaint about the eye drops is the cost. Although Mrs. Baker has a car and a driver's license, she does not drive very often due to the problems with vision. She prefers that friends and family members take her places she needs to go. At her latest visit to the ophthalmologist, the doctor notices that she has an increase in intraocular pressure. So based on the information provided, what might be the cause of Mrs. Baker's increased intraocular pressure? She probably has open-angle glaucoma, tends to be chronic, and becomes progressively worse. So that's probably what's going on with her. I'll let you think of the priority nursing diagnosis with this and what type of resources might be available to help Mrs. Baker meet her needs. It looks like her vision is really getting a lot worse, and it seems to be obviously affecting her quality of life and her normal activities of living. Mrs. Baker may obviously need transportation to get around, obviously for doctor's appointments, to buy her groceries, and for somewhat of her socialization and her social time. She may need some assistance with the cost of her glaucoma drops. Doesn't seem like she's bringing in a whole lot of money, and I don't know exactly how much these ophthalmic solution eye drops cost, but it is a big concern, and my only concern is that with the cost of these, she may not take them as they're prescribed, and this could lead to more progressive problems with her glaucoma. There are some of these drug companies that offer some financial assistance with some of the drugs that these patients are on. Sometimes the docs can get some discounts or coupons that provide the patient with quite a significant reduction in the cost of these medications. She may need some help with maybe Meals on Wheels, maybe with her sight being somewhat deteriorating. She may not be able to cook or prepare foods. And again, it's always about safety. And of course, with osteoporosis, I'm always concerned about the risk of falling and definitely developing or having a fracture or a broken bone occur. So she might also need some assistance with walking, maybe a walker or a cane, just to keep her steady on her feet so she doesn't risk the chance of falling. Okay. So those are things that we could obviously provide for her, because she really is in very, very good, excellent health, and that's a great thing for her. All right, so that was Appendix 44, having to do with the exemplar of glaucoma. And looking at the concept of safety with glaucoma, I'll let you think about some of the answers to this. What interventions are appropriate for the nurse to initiate to ensure safety for this for the client with glaucoma? I think we've talked about that. Why would it be important for the nurse to give anticipatory guidance to the client with glaucoma? And then we have a patient here who is a 40-year-old woman with severe persistent asthma. In addition to receiving bi-monthly immunotherapy, she takes an inhaled corticosteroid with long-acting beta agonist and an antihistamine daily. Each year she has 4 or 5 acute exacerbations of asthma that usually require a taper of oral prednisone. So what are her risk factors for glaucoma? I want you to think about that. She's only 40, so really age is not one of her risk factors. I think one of her big risk factors is the fact that she's on corticosteroids for her exacerbation of her asthma and her comorbidity of asthma. So long-term steroid use may be a contributing factor. So that's definitely her risk factor. What client teaching should the nurse provide Mrs. Parkerson to reduce the risk of developing glaucoma? Definitely seeing her doctor on a regular basis to be sure that they can catch it early if she should develop a glaucoma. Exercise helps to lower intraocular pressure, which can help to reduce the risk of developing glaucoma. The only thing is you have to be very careful of certain yoga poses, that if that's what she tends to do, because if it bends below the heart, if the person bends below the heart, it can increase intraocular pressure. Maybe it might be important for her to eat a healthy diet and to continue taking maybe some vitamins that are high in zinc and omega-3 fatty acids, keeping her weight under control, preventing overexposure to sunlight, and definitely not smoking. And I doubt if she's smoking with her history of asthma. So those are some things we can explain to her to do. All right. So the last little activity, or kind of a recap of all the information about these eye disorders, is macular degeneration. And so Margaret Marlborough, 58 years old, is a librarian in good health. She has never smoked and has no history of heart disease. She has made an appointment with her ophthalmologist because she has noticed pages getting blurred, and she sometimes cannot see her co-worker's face clearly. And at first she thought her glasses might be dirty, but cleaning them didn't seem to help. Based on the information above, what visual examination will be performed? So what we would do for this patient, obviously, she would need vision and retinal examinations. The one thing they can do is this Amsler grid, and that is on page 1418 in your book. And it almost looks like graph paper. Within the center of that is like a big bolded dot. So patients with wet AMD will report the same symptoms as those with dry AMD, with the addition of visual distortions, okay? Usually what else they'll do is a pupillary dilatation exam to really look inside. And then What else will they do? They will also do angiographies can be done. OCT, which are those optical coherence tomographies, which basically is relatively new. And the good thing about it is it's a non-invasive type of diagnostic study. And what it does is just take pictures, as I said earlier, of the retina to measure its thickness. And people that have thinning will be recognized as people that have advanced age-related macular degeneration. So those are some things we might do. So what type of age-related macular degeneration is Margaret's likely to have? So with what her symptoms are, what do you think she has? Do you think she has the wet, or do you think she has the dry? And the dry is also called, remember, non-executive, and non-exudative macular degeneration begins with the accumulation of these deposits, and those are called what we might know those as drusen beneath the pigment epithelium of the retina. And wet macular degeneration is exudative macular degeneration, and that's where you have that vascular endothelial growth factor. And what's happening with them is, as I said before, is that just promotes the growth of these very fragile and very unhealthy type of blood vessels that tend to seep and leak out blood, and then it also presents scar tissue. So I want you to think about what is going on with her. I think she has the dry, which is the most common form. It accounts for about 90% of all the cases of people who have macular degeneration. So I want you to kind of come up with your own priority nursing diagnosis and think about what interventions will be most benefit to Margaret. Obviously, her diet will be very beneficial. High doses of antioxidants and zinc may be very beneficial. All right. So lastly, on Appendix 47, and I'll let you work on this. A lot of this information you can find from the PowerPoint or from your reading. What challenges might the client with late-stage age-related macular degeneration experience related to physical activity, and what effect might age-related macular degeneration have on the patient's ability to maintain good dental hygiene, and then think about this in collaboration with cognition. What effect might advancing macular degeneration have on a patient's cognition, and what strategies can the nurse implement to promote cognitive functioning? So I'll let you work on those and come up with things, and we can talk about those in our WebEx. For those of you that would like to join, we'd love to have you on board. Well, this pretty much concludes our online lecture related to stress and coping, and then of course to cognition, and of course to the eye disorders of cataracts, glaucoma, and macular degeneration. Have a nice day, and thank you so much for your attention.